finally about to happen. Um, First, I wanted to introduce Mozzie, and the team at Mozzie is here today, and they're going to be explaining everything about the trial. Um, I initially met Mozzie, well, I initially met Yael, who's the CEO of Mozzie, about 7 years ago. At that time, she was working for a company called Ultragenics, which is a biotech that has done quite a few therapies for rare diseases, including some genetic therapies. Um, she and I met at a boot camp she was running to teach rare disease organizations how to get their own therapies moving. And she saw a great unmet need and decided to start her own company, Mozzie, to help rare disease communities like ours. And that's exactly what they've done. They took the work that you all helped us fund from the University of California at San Diego, Dr. Allison Moultrie's lab, in gene therapy. They licensed it, and they've spent the past 4 years getting it ready to bring to trial, and that's where we are. We're about to start recruiting in the next couple of months. So it's really exciting, and we're really grateful to have them on our side and working for us. Uh, we just wanted to remind you all that afterwards there'll be a Q&A. But please try not to ask about specific patients. Keep your questions general. Uh, the team from Mozzie and will be unable to answer anything specifically about your child. So try to just keep it general. We also have on the call Dr. Diana Wally from Colorado Children's Hospital from our PittHopkins clinic there. Dr. Wally, would you like to introduce yourself?
Um, I'm Diana Wally. I am the medical director for our chromosome 15 and related disorders multidisciplinary clinic. And I'm a neurologist and epileptologist, and I'm extremely excited about this trial and where we'll go with it.
Great, thank you so much. And now I'd love to hand you all over to Dr. Yael Weiss, who's the CEO of Mozzie and leading this trial.
Great. Thank you, Audrey, and thank you, Dr. Wally, for joining us. Yeah, I'd like to tell you a little bit more about Mozzie, about the gene therapy that we're about to administer in the upcoming clinical trial, and then hand it over to my team members, Sam and Emily, to talk about the trial logistics and the trial itself. So what we wanted to start with is to make sure that you all understand that MZ1866, which is the gene therapy that we're about to talk about, is an investigational medicine. It has not been approved by the FDA or any other regulatory agency. So we are talking about a drug that is now going into the clinic, into clinical trials, and the first time tested in human beings. The information that we're providing is educational. It's not medical advice. All of you have great clinicians that are treating your families. And if you have any specific medical questions about your children or about the family, please advise with your treating clinicians. We are providing this information in this webinar as an overview of the trial and trial participation. It'll be obviously your decision whether to enroll, and you will be able to consult with the site investigators in the sites that we'll be conducting the clinical trial, and get more information from them about the trial and make your decision whether it is right for you to participate or not. And of course, any medical questions should be discussed with your clinician. Next slide. So a little bit about Mozzie. Audrey already introduced us. In the center, you'll see the Mozzie team. We've all been in the rare disease space for many, many years, all experts in neurogenetics and neurodevelopmental disorders. And we came together to develop therapies for neurodevelopmental disorders as a team that has experience from the basic research into the clinical proof of concept and commercializing these medications. You'll see on top the PittHopkins Research Foundation. As Audrey said, we met 7 years ago, but the interest in this specific program actually happened as I was listening to a PittHopkins Research Foundation Science Day, and I heard Professor Motri talk about the gene therapy that he developed, and it was clear that this is a therapy that needs to be tested and needs to be taken into patients because their data was very compelling. So we then approached the University of California, San Diego, and requested to take ownership of this gene therapy, and now it is a MAZI program, and you'll hear more about it in a minute. As a small virtual company, we work very closely with diagnostics companies to find more PittHopkins patients and make sure that everyone that has a mutation in TCF4 actually is diagnosed and knows about this community, this amazing community that all of you have with the PittHopkins Research Foundation. And we also work with various research and manufacturing partners that help us develop the therapies and make the gene therapy that will go into human beings. Next slide, please. So a few words very quickly for those who don't know what a gene therapy is. As you know, our body is made of proteins, and these proteins are actually coded by DNA that is in each of our cells. So it's like a book with many, many, many letters. And imagine buying a book and one word has a typo in it, and that's the mutation in TCF4. What we are hoping to do with our gene therapy is to override this typo in the genes and make the normal protein instead of the mutated protein by giving the body the normal gene. So this is the gene therapy, giving the normal TCF4 that will go into the cells and override the mutated TCF4 and make enough normal protein so that the cells will function better. So we use this therapy by administering a virus, and all of you know what a virus is. We just went through the pandemic, and we all know what the coronavirus is. We are actually using a different virus that is harmless. And what we do is we take out all the guts from this virus, and instead of the normal contents, the virus now has TCF4 in it, and it can infect the cells, just like the coronavirus infected our different cells in the body and caused the symptoms. This virus will infect the cells, will not cause any symptoms, but will deliver its contents into the cells and enable the cells to make normal TCF4. Gene therapy is given once. The virus goes away. Just like we heal from many different viral diseases, this virus will go away. But the DNA that we put inside the virus, the gene, the normal TCF4 gene, will stay in the cells and continue making normal TCF4. Next slide, please. So this is the virus. On the right-hand side, you can see a schema of what a virus looks like. It has a very specific shape, and you can see that the TCF4 gene inside the virus. We add to the TCF4 gene various elements that will make the protein. And the virus, this specific virus that we are using, likes to go into nerve cells, into the neurons. So it will actually put the normal TCF4 in every cell where TCF4 is normally expressed. So it could be neurons, which is our most important target, but also other cells in the body that express TCF4 will be able to express the protein from this virus. The virus, as I said before, goes away, but the TCF4 will stay inside the cells. And one thing that Sam will talk about in a few minutes is that just like any other viral infection, our body sees, oh, something strange is coming into our body and we need to try to get rid of it, there may be an immune response to the virus. And this is why we give steroids in the trial to try to reduce the body's reaction to the virus coming into the body. Next slide. Here I just wanted to go quickly through the different stages that we went through and that enabled us to actually go to the regulatory agencies, to the FDA, and ask them if we can start the study. So the first question that we asked is, does the drug work? Does the gene therapy work? And on the left-hand side, you can see a dish with little blobs in it. These little blobs are actually mini brains that were made from patient cells. So patients in this community donated their cells, and Professor Motri, in a tissue culture dish, made mini brains. And that was the first place where he tested whether the gene therapy is working. And he was able to show that these mini brains are different from the parents or from the brothers and sisters. But when he gave them the gene therapy, they became more similar to the parents and to their siblings' mini brains. So he was able to get as close as possible to normalizing these mini brains' structure and function. The next step was to test it in mice. We injected the gene therapy into mouse brains. The mice have a mutation very similar to what some of the patients have. They have a deficiency in TCF4. And we were able to show that when we inject the gene therapy into the mouse brain, we are able to restore some abnormal behaviors that the mice exhibit when they are missing TCF4. This data will be shared in the future. We'd like to be able to collect all the information that we actually use in our FDA filing and present it to the PittHopkins community in a more digestible manner. A lot of tests were done. We looked at different behaviors in the mice, and we also looked at the brain and the nerve cell structure, and we were able to show that these behaviors, as I said, were corrected, and the brain cells look more normal than they did before the injection. Then we tested whether the drug is safe, and this is a testing that we do in monkeys, or as we say in professional jargon, non-human primates. And we were able to show that the gene therapy is safe in the doses that we are intending to use in the clinical trials in human beings. And then we took all the information that we had and we went to the FDA and asked the FDA whether they agree that the drug works and that it's safe, and can we start a clinical trial. And in September, we received clearance from the FDA to start the clinical trial. Next slide. I'll hand it over now to my colleague, Sam Collins, who is our head of clinical development, and he'll tell you a little bit more about the study.
Yeah, hi everyone. Thanks, Yael. So as Yael laid out, we're going to give an overview of the study structure here and really try to give you a good flavour of what taking part in this study might involve, the time commitment and the procedures that are needed in the clinical trial. So the kind of key features here, this is what we would call a phase 1/2 clinical trial. So phase 1 is obviously the first phase of development in the clinic, which means this is a first in human trial. So this is the first time the treatment has been given to humans, and a first in patients. So it's also the first time this treatment will have been given to those with PittHopkins. Sometimes you will see those as separate trials, but in this case, because it's a gene therapy, those two things occur together. And because of that, our primary objective here is to establish the safety. So safety is always our prime concern with anyone taking part in the study. We demonstrate that this both works in patients, but is safe for them to receive it. So although our primary objective is safety, then our secondary objective is a number of different endpoints to look at the effectiveness of this treatment. And this will both obviously demonstrate that the treatment could work, but will support the future studies that we hope will eventually lead to widespread availability and approval of the treatment. In terms of where we're conducting the study, so it's in 3 countries, in the US, in Israel, and in Spain. And within the US, we have 3 sites, Oakland, California, in Denver, where Diana is, who's joined us on the call today, and then at Rush Medical Center in Chicago. I'll talk a little bit later on about when those sites might be ready to start enrolling patients and the current status. But these are our 5 sites. Because of the nature of the study and planning we've done in the startup, there's no plans to add additional sites at this time or countries. So these are the 5 sites that we'll be using for the study. Here's a sort of flow chart of how this study will look. So the first thing to say is that everyone in this study receives the same dose. So there's no high dose and low dose cohorts. There is a single dose That's based on those studies that Marzi have done and that Yale talked about in terms of both the effectiveness in the preclinical work of the treatment and the safety. What I'll highlight here as well is you can see there's a number of those yellow diamonds, and this is our data safety monitoring board. So we have an independent panel of 3 experts. They're external to Marzi. They're not involved with the company, and those are experts in PittHopkins, in gene therapy, and in immunology, so the body's reaction to gene therapies. And at each stage where you see a yellow diamond, that's when Marzi is reviewing the data, ensuring that there's safety to move forward with the study, and also discussing that with the external experts. So really ensuring that at every step of the process that safety is paramount. The first cohort in grey, these are the slightly older children, and young adults, 12 to 25 years of age. So there'll be 6 of those. The first 2 patients go one by one, and then we enroll the rest of the cohort as we move on to the younger children. So as you can see, there's 8 weeks indicated there, so it will take some time to move through the first cohort before we go to the younger kids. The ages here are inclusive, so the first cohort could be 12 years of age, it could be 25 years of age, or anywhere in between. Same with the second cohort. As you are screened and enrolled into the study, you must be 2 years of age or up to 11 years of age. I'm going to talk now a little about the inclusion and exclusion criteria. So just to clarify what this means, you must have all of the inclusion criteria. So these are the characteristics that you need to have in order to be included, and you must have none of the exclusion criteria. So if you have any of the things on that side of the list, unfortunately can't be part of the study. So this is not an exhaustive list. There are a number of things that you would discuss with the investigator, but this really gives you the highlights of things that you might consider if you're thinking to take part. We already talked about age. So at the screening, you must be between 2 years and 25 years inclusive. So that is at the first enrollment into the study, you must be in that age range. There must be a documented mutation in the TCF4 gene. So we know PittHopkins is caused by TCF4 mutations. There has to have been an analysis by an accredited laboratory that shows that the mutation is pathogenic or likely pathogenic. So they're the technical terms used by the genetics labs to define mutations. And then we list the technologies that should have been used. Any recent analysis will use those technologies. Sometimes there are much older tests that used previous technologies that might require a repeat. But essentially, you need a report from an accredited laboratory that documents these things about the TCF4 mutation. One exclusion related to that is that if it is a deletion, it cannot be more than 12 megabases in size. The reason for this is because when mutations become that large, they often cover other genes and result in a different type of disease than strictly PittHopkins on its own. And that can have 2 effects, really. It could mean that we aren't able to fully assess the safety of the gene therapy or the effectiveness when there are other genes affected that are adjacent to TCF4. And some of our experts in PittHopkins have shown us that the data they have indicates this is important for us to clarify before we undertake the study. Other medical problems, we realize there's a whole host of other problems that are either related to TCF4 and PittHopkins or related to other things. We can't be exhaustive in this list, so that's another thing that needs to be discussed with the investigator. They'll decide whether there's a safety issue or a problem that might prevent you undertaking the study. One of these things is about the brain anatomy and the brain blood vessels. So this treatment needs to be administered by a small neurosurgical procedure, and anything that would make that potentially unsafe would preclude from the trial. And one thing that doesn't completely exclude you, but does affect the timing, is you cannot have had immunizations or an acute illness within 6 weeks of the baseline visit, because we know from gene therapy trials in the past in other indications that this can increase your risk of having a reaction to the treatment. So we want it to be well and not have your body primed to be fighting infections as the dosing occurs. And this baseline visit is the one that happens just immediately before dosing. Other things to consider. So obviously there'll be a lot of medications that people are on for various different things, including potentially seizures, behavior, and certainly the significant issues with constipation. We'd just like that those be stable for the 30 days before screening. So if there are current issues that require a lot of tinkering with medications or changing doses, I'd like to have that relatively settled before the study so that we can truly assess whether the treatment has improved those things and not still be changing other aspects of care while we're assessing the gene therapy. Another thing that's important for the assessment of the data in the study is that you cannot have received any previous gene therapy because your body will likely react to this one. And you cannot have received any investigational treatment for Pitt-Hopkins syndrome. What this means is if you have been in a clinical trial for Pitt-Hopkins, not just gene therapy, so any oral medication or otherwise, you cannot be in this study because this will affect our assessment of both the safety of the drug and how effective it is. And when we eventually take these results to regulators and say we'd like to progress the study or we'd like to move towards an approval, they can say, oh, you don't know whether the effect was due to your treatment or due to the previous investigational treatment they received. So it's important for us to know that anything we see in this study is from MZ1866 and not from previous investigational treatments for Pitt-Hopkins. Other clinical studies that don't involve a drug or a treatment, that's fine unless you're having neurodevelopmental assessments such as the Bailey or the Vineland, because it can affect the data if you're having those too frequently. And as we talked about before, you do need to receive corticosteroids to be in the study. So any reason that you couldn't take those would preclude participation, and any reason that you wouldn't be able to have a MRI scan and then undergo anesthetic for the neurosurgical procedure would prevent participation. And one last thing that we do need to mention is that you have to have an undertaking not to share any study-related information on social media. And again, this is about the data that we share eventually to support this program advancing and moving towards approval, because sharing an experience of improvement for your child could affect how someone interprets their data and then could affect how others see the data we present if the trials are successful. So this is a picture of the kind of commitment when undertaking the treatment, because although it is a one-time treatment, there's a lot more to the study in terms of follow-up, just to ensure safety and also to ensure we can see whether this treatment is having the effect that we hope. The blue dots you can see are the times you need to attend clinic. Some of those include a stay in hospital around dosing. We have 3 home health visits, and then we have 3 visits where it's done by telehealth or phone. So the time commitment is quite intense early on around the dosing, becomes less so as we move out through the trial, but it is essential that all visits are attended for the safety of the participants and to get the essential data we need to show that this treatment is working. A little bit more data on this. So before the treatment, there are various tests we need to undertake to make sure that you're eligible for the study and that it's safe to proceed with it. One of those includes an MRI scan where the brain and the blood vessels in the brain are assessed for the neurosurgeon. The therapy itself is given through a short surgical procedure. So the fluid around the brain is accessed with a silicone catheter that's placed by the neurosurgeon, and then the treatment is injected into the brain. The infusion itself only takes a few minutes, but the whole procedure may take longer, and after I've done the summary, I'll get Diana to talk a little bit more about the specifics of what might happen in the hospital. There is a requirement to stay in hospital for around 3 days after the treatment, so this ensures that the monitoring of the recovery from the neurosurgical procedure and the body's reaction to the treatment. And leading on for that, then we'd arranged to stay nearby to the site for 14 days afterwards. This is really the critical period of monitoring for any reaction of the body to the treatment and ensure that you're right close at hand should anything arise or any concerns from you. Nurses will visit the home, and that's really again around the body's reaction, so that the liver has to work very hard when you give a gene therapy, and part of the reason for giving the steroids is to manage that reaction, and we need to monitor closely how it's responding to that. The study lasts 2 years. There is a requirement to follow anyone who's had gene therapy for a total of 5 years, but within the confines of this study, it covers the first 2 years. And as you can see there, through those 2 years, you would need to come back after a month, 2 months, 3 months, and then 6, 12, 18, 24. So it is intense at the start, and then there is a regular return to the site to assess progress. The home assessments are early on, monitoring that liver reaction to the treatment. To go into a little more detail about the procedure itself of how MZ-1866 is given. So as we keep saying, it's a one-time treatment. It's given directly into the fluid that surrounds the brain, so the CSF, cerebrospinal fluid. That's what circulates around the brain, much like blood does around the body, to provide nutrients and take away waste products. But it means that we can give the treatment directly to the area that's most affected by PittHopkins syndrome, and optimize the access to the cells that need the treatment by giving it directly to the CSF. There is as we say, a small hole in the skull made by the neurosurgeon, and the catheter is inserted, and then the medicine is given through that. They will look at the MRI to ensure that it's safe and to see which path they're going to take with that catheter. And obviously fully asleep and anesthetized during the neurosurgical procedure, and then staying in for 3 days after that to ensure that there's a full recovery. Just a couple of pictures to demonstrate that. So on the right here, we've labeled the lateral ventricle, so the fluid space within the brain that will be accessed by the catheter, and that's shown on the left. It's injected through that catheter. Once that is finished, that is then totally removed and go back to the recovery area. So why do we use this ICV, as it's called, administration, so intracerebroventricular administration? Well, this is about getting the treatment closest to where it needs to be. So there's been a lot of work supporting the fact that if you administer it to the ventricles, you get a better access of that viral envelope to the cells in the brain structures that are most affected. And really, that has become the optimal route of administration in a number of different gene therapies that use this type of viral capsid to treat neurodevelopmental disorders. The other thing it can do is it provides a relatively long-lasting supply of the new gene. So the more of the cells that you can get the treatment into and leave that DNA behind, the better, more long-lasting the effect on the nervous system. Just moving to other treatments given in the trial. So we've mentioned a few times that steroids are necessary to moderate the body's immune reaction to the gene therapy. The steroid medicines would start 1 day before receiving MZ-1866. They would continue for 28 days and then will be slowly reduced over another 28 days. The monitoring during this time is about blood tests that look at the liver function. So the treatment with the gene therapy can be monitored by the liver's reaction to that gene therapy. If the liver tests are normal, we proceed as it says there, 4 weeks of treatment and 4 weeks of tapering down. If they're not, the steroid treatment may need to go on longer and will be modified to settle that inflammation. There are some other tests that are needed. We talked about the MRI scan that occurs before treatment and then once a year in the study. That is likely to be done under sedation, so not fully anesthetized like for the neurosurgical procedure, and the same for the lumbar punctures. So that happens 4 times through the study, where we monitor the effect of the treatment on the spinal fluid. However, we can take it from the lower back for those samples. And obviously the medical team at the sites are experienced in these types of treatments, and they have experts there to work with you and monitor for any reactions to the treatment and any additional medications that might be needed because of that. Just to return back to the sites where we're conducting the study, as I said, in the US there is 3 sites. So in Chicago and in Oakland, California, the sites should be set up and ready to go early in the new year. This means they should have everything in place that they need to start thinking about enrollment. Colorado, we think, should follow a few months after that. Israel, likewise, early in the new year. Spain, there's a few more technical issues to work through, so that would likely be more towards the middle of next year. On clinicaltrials.gov, there will be updates as they progress, so you'll be able to see both the state of the sites and the when we move from being in this startup phase to openly recruiting. So what I'll do now is just hand over to Emily, who will cover some of the more logistical details of taking part in the study.
Thanks, Sam. Hi, everyone. I'm Emily Rademail. I lead clinical operations for Mozzie, and it's nice to be here with you today. We can go to the first slide. So as Dr. Collins described, there will be some home health visits, 3 of them. This is where a nurse will come to the participant's home to conduct a few study assessments. The nurses will have pediatric experience, and their qualifications are going to be approved by Mozzie, the investigator at the study site, as well as the hospital's ethics committee. They'll come to your home or the participant's home or another mutually agreed convenient location. They'll bring equipment with them to collect vital signs, to collect blood and urine samples, and they will also ask some study-related health questions. During the informed consent process with the study site, they will explain more about the home health nursing visits. Next slide. Okay. Dr. Collins also described that there are 11 total clinic visits that are required for the study over the course of 2 years. And depending on the distance between the study participant and the study site, these visits may require travel as well as overnight stays by the hospital. So Mozzie will cover the cost of travel and accommodations for the visit. We hired a concierge travel service that specializes in supporting clinical trial participants. What they do is they arrange and prepay for flights, hotel, and long-distance ground travel. They can also arrange for any special equipment or other special support that may be needed during your stay or during your travel. In addition, they process and provide reimbursement for any reasonable out-of-pocket expenses that may have been incurred. Again, more information on travel and how this works will be provided by the site during the informed consent process. Next slide, please. So in terms of overall timelines and sharing study results, as we've mentioned, this is a 2-year study. Enrollment in this study is planned to take approximately a year. It's staggered enrollment, so not everybody enrolls at the same time. It's staggered. And so for that reason, any indication of whether the study drug is working will take some time to understand. That being said, safety data will be collected and analyzed in real time. Any significant, important safety information will be shared publicly. And this is really both for the benefit of this community, but also for the wider gene therapy community as well. Next slide. Dr. Collins mentioned the exclusion criteria or the inclusion criteria that participants in the study need to agree not to share trial details on social media or with each other. We know that social media is really an important way that you may be getting support, you're sharing important information, and creating community. So it may sound like a strange request, but really we ask this to ensure that we maintain the integrity of the data that we're collecting. This is an open label study, so that means that all participants will be receiving study drug, and all parties will be aware of that fact. So what you post online about how your child is feeling, behaving, what they're able to do or what they're not able to do while they're participating in this study could influence how other participants notice or talk about their own child's experience. And this could ultimately bias the results of the study, which would be very unfortunate. We want to make sure that this trial is as objective as possible. And so, if you have any questions about this, please ask the study site of the PI when you go through the informed consent process. I'm also very happy to share resources on the topic of avoiding bias in clinical trials. So that is all I have for you today. I'll pass it back over to Dr. Collins.
That's great. Thank you, Emily. So we've made some time here to address the questions that we received. We got a lot prior to the webinar, so we've got many to work through, and then hopefully get through as many as possible of your questions that you've submitted today. So jumping straight in, many people have asked about other medical issues. As we said, we can't address specifics here, but often the discussion is, we have these other issues. Would it stop us taking part in the study, or will we be able to? And will the criteria be changed at the time in the future? So I'll hand over to Diana in a little bit, but just to say that the nature of the study is that the inclusion and exclusion criteria are fixed. So we must set those up front. We must decide with our experts and talking externally what the most appropriate set of patients for this study are, and then they're fixed so that we don't then amend things for people or look to be cherry picking patients based on who we want, and again protects the integrity of the study data. So we cannot waive any of those inclusion or exclusion criteria, but the site investigators will discuss with you about the appropriateness of taking part if there's anything else going on. I don't know if Diana, you want to talk a little bit about that as well?
Absolutely. So talking with whoever the PI is or clinician is who is running the study is very important. All will be very happy to answer any questions, but the inclusion/exclusion criteria is really for safety of the child, of the patient. And this is not a small undertaking, and so we are as an investigator, number one priority is safety for the child. And so if there is a possibility that this would be unsafe, I will have that discussion with you. And again, that's why those parameters are put in place.
Right. Thanks, Diana. And the another question that probably leads on from that is some people have been asking, do we collaborate with other companies that are working in this space? Do we take into account the learnings from gene therapy programs that have had safety issues and side effects from these types of treatments? Just to say, yes, we do. It's great working in rare disease and ultra rare disease on these kind of indications, because companies really have a vested interest in making these treatments as safe as possible for everyone, and to get everyone's programs advanced so that many different communities have treatment options. So we're aware of the safety issues that have been brought up in other trials earlier this year. I will say that what those trials revealed is that there are some doses which appear to be safe to dose up to. We're taking heed of that. We're not going to go as high as some previous programs have gone where there have been significant safety issues. So we have taken that into account. And the other thing is to be very focused on the safety and the monitoring. So the stay in hospital for 3 days, staying close to the site for 14 days, and also the clear plans in the protocol about how to monitor and what to do if there are issues have really come from collaboration and learning with other programs and other sponsors as well. And Diana, if you want to say something about what goes on at your site in terms of the safety and the monitoring.
Yeah, the safety and monitoring again is very closely monitored. At our site specifically, we have an escalation protocol, as well as through the protocol that they have. I've sat on, or I sit on a group, and we are constantly looking into this and constantly changing to ensure that we can respond as quickly as humanly possible to try and decrease the risk.
Thanks, Diana. So the other question we get a lot is about participants from outside of the countries that we're planning to run the study in. So as I said, we're not for this study planning to open more countries or more sites, but we do hope a successful study could lead to expansion or further trials to support approval of the medication. International participants are not specifically precluded from taking part, but it is up to the individual sites how they're able to support that. You must be able to attend all the study visits, so you need to be able to be admitted to hospital, stay at the site for the time afterwards, and come back for every site visit afterwards. And then you also need to be able to read, understand, and discuss the full informed consent process in the local language which those materials have been prepared. Dan, did you want to talk a little about how you deal with international patients as well?
Yeah, so in other studies, we have been able to enroll international patients. The biggest, I think, sort of barrier is a medical visa. And if you can have the medical visa and have the time, I believe it is absolutely reasonable to consider being able to participate. But you do need to apply for the medical visa if you have any interest in this trial sooner rather than later.
Thanks. A couple of things I'll direct towards you, Emily. People are asking about how to register interest, how to enroll, and details around that.
Yeah, so the best way to enroll is to stay tuned for, we will be announcing the sites, their contact information, and who to contact just as soon as those sites are ready to receive patients. So as Dr. Collins showed before, there was the table of when the sites, we're thinking the sites will be ready. Once they are ready, and we call it activated, we will post their information on clinicaltrials.gov. We will also be sharing that information with the PittHopkins Research Foundation, so it will be published in 2 places.
Okay. And Emily, just to confirm, someone's asking the home visits, that will be wherever you are located. If you're in the US, they will attend your home. You do not need to go back to where the study site is.
Correct. Yeah, correct.
Great. So some questions about the procedure itself and things around it. So Diana, perhaps I could get you talk a little bit, firstly about how long the procedure for administration would usually take, and also about how whether the parents can or caregivers can be with the patients. What, are they with them during the MRI, during the LP? What happens around the procedures at your site?
Absolutely. So for both the LP and the MRIs, we do it as outpatient procedures in what we call our procedure center. And we use conscious sedation, meaning we give as minimal medication as humanly possible. A, so the kiddos don't feel anything, and B, so they don't wiggle, especially for the MRI and for the LP. I think if I needed either one of those, I would probably also need some medication not to wiggle around. But it's very, very short acting. We typically use something called propofol, which only is in your system for 30 seconds to 2 minutes. so it can be quickly turned off. The longest actually is the procedure for administration of the med, while the actual procedure is not very long, going into the room, in the operating room, making sure everything is sterile, making sure the positioning, which honestly takes the longest, and making sure that the patient is in the right position. And so we typically say 2 hours. For the LP and for the MRI, you can go at our site, you can go as far back into the room during the actual procedure. We have you step out, and then you can be with them immediately after, even before they wake up. And then, unfortunately, for the operating room, we can't, just due to infection precautions, we aren't able to have parents go back. But the nurse calls every 30 minutes at our site, every 30 minutes, to let families on their cell phones, to let families know how the procedure is going. And just to say everything's good, and we expect this to be the end time.
Thanks, Dan. There's quite a few questions we get about the dosing of gene therapies, and to clarify about redosing or participation in the future. So just to reiterate, this is a one-time treatment. You'll receive the dose once in the study, and then there's no ability to top up or redose, because once your body has been exposed to this virus, if it were exposed again, it would produce a very strong reaction, and that would probably clear the virus before it ever got a chance to have its effect of getting into the nerve cells. So as it currently stands, gene therapies cannot be redosed, and that's one of the particular reasons you can't have had any gene therapy for anything in the past, because of priming that body reaction to the viral capsule. In terms of how we modify for future studies, yes, we do hope that this trial is successful and that we can demonstrate that this is an effective treatment, and then we can expand and study further to support approval. That is all dependent on what we see in the study, what comes up, and then the discussions that we have with regulators such as the FDA and the EMO with that data on the path forward to approval. So plans for the future aren't set, obviously, until we know what's happening with this study. There are a few questions about specifics on what might preclude or not from participation in the study. Again, we can't really go into individual details, just to say that those are things that need discussing with the study investigator, dependent on your particular family situation. The other questions that we had about local languages. So this is specific to the country, and the potential participation could be discussed at the initial steps with the investigator. One question we got, maybe Yael, you want to talk about the back to the basic science, is whether this treatment is related to the types of mRNA that you see in vaccines, or such as the COVID vaccine, or whether it's a different type of treatment.
Thanks, Sam. So this treatment is different from vaccines. When we get a vaccine, the idea behind the vaccine is to actually stimulate our immune system to make antibodies and be able to fight any bacteria or virus that comes into our body. So in our case, we do not want our body to make any antibodies. We do not want an immune response to happen. So it's actually exactly the opposite than getting a vaccine. So it's not related. It's not the same technology. And the goal is to achieve something very different than what we are trying to achieve when we vaccinate someone.
Thanks. Questions we've got about the flow of the patients through the study. So what happens if we see safety issues, or if there are things happening early in the trial. So those little yellow diamonds I talked about, where we review with the the external experts at each stage. That includes a discussion of everything that's gone on in the trial, whether there needs to be any modifications to how the patients flow through the trial or changes to what we're doing to monitor safety. So at all times, in real time, we're looking at the safety data, we're looking at what's happening with the patients, we're in touch closely with the sites, so that anything that occurs, we can process, discuss, and decide if anything needs to change. So just to say that that's our primary concern, is to stay on top of the safety of all the participants in this study. While I look through a few other questions, is there anything else that Yael or Dan would like to comment on what we've seen today?
We try and make the whole process as painless as possible, even though it doesn't seem painless. At our site and at most children's hospitals, we have all sorts of things in place. So when we first meet you, during the consent process, we'll talk about things that make your child more comfortable, whether it's weighted blankets, spinny toys, whatever it is, and we will try and have those things available, as well as with child life, no matter the age of the patient, and really try to, especially during the time in the hospital, we have sleep-safe beds or canopy beds, and have child life available 24/7, and have our nursing team is very, very comfortable with all patients PITT and PITT-like. And so really just trying to make it as painless as possible, both for the patient and the family. You can typically have 2 parents or 2 caregivers. It doesn't have to be a parent. During cold and flu season, if it is not cold and flu season, we can typically get exceptions for more. We can also have caregivers switch out. It doesn't have to be the same person the entire time. So we are really willing to accommodate to make this really as smooth and hopefully minimally interruptive as humanly possible.
Thanks, Dana. A question
I'd
we
like
did.
to say a few words, maybe.
I'm sure, yeah.
People are asking about the mouse studies. As I said in the beginning, we will make this data available in a simplified manner for the PittHopkins community. The mouse model that was used is a mouse that has a mutation in TCF4. So being a mouse, as much as a mouse can represent a human being, it is a mouse that has some abnormal behaviors that we were able to correct with the gene therapy. And a lot of questions about the mouse and the in vitro, the mini brain studies that we conducted. Please remember that the mini brains are brains in a plate. They're not a full human being, and the mouse is a mouse. So we have seen promising data that we were able to correct abnormalities in the mini brains and in the mice, but we will know the definitive answer of whether this therapy is working or not when we treat human beings and PittHopkins patients.
Thanks, Yael. A quick clarification on some of the questions we've got about cost of procedure. So just to reiterate that there is no cost on the family. Our vendor deals with travel expenses, costs of staying close to the site. And the site will undertake the procedure that is not paid for by the family or the participants, or costs of participation are covered. And then in terms of selecting patients, how they're done, well, it's not done by Marzi, and that's why we set those inclusion-exclusion criteria up front. They are defined and set, so Marzi does not choose patients, select patients, or decide who one versus the other goes into the study based on those criteria. The site themselves will do the enrollment within those criteria and based on the discussion with you as the family. So are you able to undertake the study, attend all the site visits, travel, all of your circumstances and other medical issues that are going on really are discussed with the investigator as suitable to undertake the study. And then looking back at that schema, obviously it's not that everyone comes in at the same time. So also it will depend on, when the slots open up in terms of we see some patients, we assess them, we look at all the data, and then we move on to enrolling others. So there's a time-based component as well. But in terms of selecting patients, just to reiterate, it is not Marzi who sort of picks and chooses. We set the criteria, and then the sites will work to recruit within those. Okay, I think we might be coming towards the end. What I might do is hand back over, as we've got a few minutes left, to PittHopkins Research Foundation for their final words.
Yeah, thank you, Sam. Thank you, Mozzie. Thank you guys so much. Since we have a few minutes, I do feel like there's a couple questions I would love that I saw that didn't get answered that are kind of important. A couple of people are asking, will there be a second clinical trial? Will there be a phase 2?
So this is a phase 1/2 technically, but we don't know. We hope so, because if this trial is successful, then we'll look at next steps with the regulators, and based on the data we have, to move towards approval. Whether there are further studies or what the future looks like beyond this is dependent on the data we collect in this study.
Okay, great. Thank you. And then another question that came up, I know in the exclusion criteria, it's talked about one exclusion criteria is brain abnormalities, and a lot of kids with PittHopkins have a small corpus callosum or a non-existent corpus callosum. Would that be considered a brain abnormality and be considered an exclusion criteria?
Could I throw that to you, Diana? Because probably better you answer than.
Yeah. So, I think small corpus callosum, not a big deal, since that is a typical finding in patients with PittHopkins. Absent corpus callosum, I think, would have to be something we talk about. I think the bigger thing more that they're trying to exclude is something like either a CAV-mal, so a cavernous malformation, which, if we inserted a catheter into the brain, could bleed, as well as sort of cortical dysplasias, because that sort of makes us think there is a second underlying disease, as we think most of what they call the cortical dysplasias. So I think those are more what we're looking to avoid is malformations that could put them at risk, or that could be related to something else. Small corpus callosum, I do not think will be an issue. Absent is one that we'll have to discuss further as a PI or as a principal investigator and clinician.
Great.
Thanks.
All right. Thank you so much, Dr. Wally. I appreciate it. All right. I think it's 8 o'clock. Well, 8 o'clock here in California. I don't want to keep everyone too long. And just to let everybody know, we're going to try to continue answering questions. There's going to be, we'll be sharing these recordings, and we'll hopefully have some in our Facebook group. If you all have questions, we can try and answer there as well. And we'll be in touch with Mozzie too to get answers on whatever we can and whatever you need, if you feel like not everything was answered today. But I just wanted to say thank you so much to Mozzie and Dr. Wally, and we're just so grateful for all of you and so excited about this. And it's really a huge monumental step for our community. So thank you guys so much. And yeah, we're looking forward to getting going.
Thank you.
Definitely. Thank you.
Recording stopped.